Well, hi there. Good to see you right here on Health Diary. I hope that you had yourselves an amazing Sunday. My name is Winnie Lubembe, and today we're coming to you from the Aga Khan University Hospital. I want to say critical care unit because we are in an ICU, getting to understand what exactly is an ICU, who gets admitted in ICU, and what are some of the care that is offered in ICU. Because according to statistics, between 30 to 45 million people across the world suffer from critical illnesses, and this is annually. So the biggest question is, what kind of care do they need? Well, we'll find out after this fact of the matter.
Intensive care unit or critical care provides specialized close monitoring and treatment for critically ill patients. It involves advanced medical interventions, constant monitoring of vital signs, and support for failing organ systems, all delivered by a specialized team of healthcare professionals.
Well, with statistics indicating that approximately 30 to 45 million adults, and this is across the globe, experiencing critical illness annually, that means that most of them would also require critical care. So today on the show, we want to understand what exactly does critical care look like, and we're talking about intensive care units, and what exactly does it look like, who gets to go to ICU, and what is the prognosis after. We're talking with Emily, who is our guest for today. Emily Ashud, who is an ICU manager right here at Aga Khan University Hospital with over 2 decades worth of experience in critical care unit. Perfect person to help us with the conversation today. Thank you so much for allowing us to come into your space. I'm tempted to say beautiful space, but I also understand that the patients who come here need really critical care. So thank you so much for allowing us to come into this space. Can we just first of all understand the ICU? Most of us, when you think ICU or when you hear so-and-so is in ICU, we think, whew, yeah, this is like, that's the end, of their life. But you're telling us, no, that is not it, right? So ICU, what exactly does, what is an ICU?
Yeah, thank you.
Mm-hmm.
Thank you, Tim, for coming, and you're welcome into our intensive care at Aga Khan, Nairobi.
Thank you.
ICU is just an ICU.
It's just an ICU.
Yes,
okay.
We need to demystify the fear that comes with an ICU.
Okay.
Our ICU is basically a position for critically ill patients.
Okay.
Patients who need more support than can be offered in a general medical surgical wards.
Okay.
Okay. So when they come here, we are talking about a patient who requires more than 2 organ support, because that's our admission criteria. They may require a renal support, whereby we'll need to dialyze them. They may be failing to breathe properly, what we call respiratory failure, and therefore we'll need to support their breathing. They may be having issues related to the heart, okay, and therefore we have cardiovascular support. They may have undergone a surgical intervention in the head, and therefore they are neurocritical patients who need neurocritical support. Okay. All that is in ICU.
ICU. Okay.
So our ICU, to begin with, is an 11-bedded ICU. They are all rooms.
Okay.
And 3 of these rooms are negative pressure in nature.
Okay.
Negative pressure, what I mean is, those 3 rooms have been built in a way that the air that is circulating in the room cannot get outside. They are special rooms, okay? And we have 4 of such rooms in our HDU, because it is our step down, okay? So the air is made in a way that there are some machines that can be able to extract that air. What kind of patients go into these rooms? Patients with pulmonary infections like TB. We also put our COVID, like in the era of COVID, we put them in those rooms, okay? And many other conditions that require that kind of isolation, we put them there.
Okay.
Nevertheless, our ICU has an admission criteria limiting our age from 2 months and onwards.
Okay.
Why am I saying 2 months? Because we have babies who are below 2 months. Those ones will be admitted in our neonatal intensive care unit.
Okay.
And therefore here, we admit 2 months and above.
Okay.
And our diversified nurses, all our clinicians have been taken through specialized training to be able to care for these patients.
For the patients, yeah. What differentiates ICU from HDU from the normal ward?
So let me start with differentiation from normal wards.
Okay.
Normal wards, their patients are a little bit stable. They don't require this kind of support that we have. In our HDU and ICU in Aga Khan, actually care is almost seamless. What can be done in ICU can seamlessly be done in HDU.
Okay.
They can ventilate, they can do plasma exchange, they can dialyze, name it. It can be done in our HDU ICU. We've brought it to that standard to be able to accommodate the number of an influx of patients that may require critical care beds, because our ICU is only 11 bedded. As we speak now, our HDU is at 26 bedded HDU.
Okay.
And in the event that I'm full here, I can comfortably nurse those patients in our HDU.
Okay.
Our nurses cross over into ICU, HDU, you know, and therefore care is very, very seamless.
Okay. But is there a difference in terms of?
Yes, there's difference.
Okay.
An ideal ICU patient will require more than 2 organ support.
Okay.
A HDU patient can be a patient who probably needs, maybe required 1 support. Maybe it was just a breathing issue. They put on some, not life support per se, but maybe some oxygen to just support them. And when you compare that kind of a patient with a patient who is in the ward, a patient in the ward may not necessarily be on oxygen.
Yes.
They may just have come because probably they had a wound that needed to be changed, or maybe a follow-up that they needed to be, you know, followed up and be given the results. Okay. So those patients are totally different. So the moment they cross over into ICU, care changes.
Okay.
Care changes. First and foremost, they will be admitted under one named physician. They will have their primary doctor who is driving the show, for lack of a better word. Okay? The primary physician is the one that dictates care for this patient. In the event this patient now develops, let's say, other organ involvement, as ICU, we have our own critical care teams made of our critical care nurses, we have critical care consultants, we have intensivists, okay? We have dietitian, we have a pharmacy, okay? Because our kind of approach to this patient is a multidisciplinary. Multidisciplinary approach, so that in the event they are doing their runs, all these people have an input to give.
Okay.
So care is driven from one person, but people will come in and add. Yes.
Yeah. So then in terms of care, because like we said, it's critical care that is needed, and the multidisciplinary team is also you know, involved. Yeah. Because most of the time, like when we see in general wards, you know, the number of rounds, you know, that are made, I want to believe that's different for an ICU patient.
Totally different.
So what exactly does that look like?
So for our ICU, like now, I need a pharmacy right here, which we have. Okay. I need medical equipment right here, which the hospital, and thank God to our chief nursing officer, thank God to our chief executive officer, they have provided us with literally every aspect of equipment that we need to support these patients. All right. And now what we just need is to provide that kind of care, that quality care, that high standard care that these patients need. Of course, as patients flow in, we will assess them with what we call a severity index. All right. Severity index basically looks at the number of organs that have been affected and what kind of support are we offering to support those organs. For example, if a patient has come in with an issue with the lungs, we automatically take over their breathing. Taking over meaning we'll put them on a life support machine. The machine will be able to assist them to breathe until that lung heals. If it's a heart issue, we invite our cardiologists who will come and do their tests, and they will tell us, use this medication, use this medication. But we still have our own critical care medication that support the heart, while the cardiology team is also supporting from other ends. Right. So those are the kind of medications which you will not get in medical ward, in surgical ward, in private wing. Okay. So the moment we have patients in those areas requiring this type of critical care medication, because it's critical care, their status will automatically change from med-surgical area to critical care. Because here they will be monitored using that cardiac monitor. Because some of these medications have a lot of effect on the heart. It will cause them to, you know, like We call it fibrillate. It will give them what we call abnormal rhythms. We call them arrhythmias. You cannot be able to see that if a patient is not connected on the monitor. Because these monitors can be able to pick abnormal rhythms. They can't be able to pick that. And our nurses and our doctors have been trained, and that's why they go for advanced training.
So what are some of the, say, conditions or, diseases or illnesses that a patient might require to be in ICU and not, say, in HDU or the general ward? I know you talked about pulmonary, diseases in a way. Yeah.
Yes. So criteria for you to come to ICU, like I had mentioned before, is if you are suffering one or two or more organ support that's required to be monitored in the intensive care. For example, let's say I'm taking an example of a mother who has just gone in for delivery. She has gone through her CS and then she develops breathing complications after delivery. You will not take that mother back to maternity. That mother must come here. So that we can be able to monitor and evaluate, is she deteriorating? What kind of other support systems does she need? Does she need, to be put on a ventilator? So that is what happens in ICU. We literally look at you systematically, per system. We will look at the head and be able to analyze, this patient has edema, this is the kind of medication we need to give, this like that. We go at the heart, we look at the lungs, we look at the kidney, we look at the skin in totality. So we look at the patient wholesomely, but per system. And if there's an organ that is requiring support in those systems, then we support it. We jump in and just support the systems. So our ICU is a medical, surgical, neurocritical, obstetric, gynecological, all those that have complicated and they are requiring support, they will come to this ICU. If, for example, there was a very stable patient in HDU and has now developed these problems, remember they were just on oxygen, and now they're needing to be supported more, automatically care again will change from HDU now to intensive. This was just high dependency, but now they will come to intensive care. So we are a team with a lot of advice from our support system. Yes.
Being in ICU or being admitted in ICU, does it mean that a patient's life is almost over?
No and yes. Sometimes. Why am I saying no? If patients present early enough, because we say time is money, time is muscle, time is brain. If they come early, we have seen very good outcomes. But with the late presentations, for sure, when it's at the tail end, we will still give our best, but of course we may not expect much, but we will give in our very best. So we've had positive cases where patients actually are discharged and they go home from ICU. Yes, we've had that. And a good number of them have actually come back to see where they were. And they're like, I'm told I was here, because they can't remember. And we tell them, yes, you are here. Which room was I? And we'll actually show them exactly the bed they were on. So we've seen some positive, some very good outcomes if they come, on time. Yes.
I see. So then it's round the clock care. And we were discussing this during the break. And you say, my nurse has to sit there and constantly monitor, my patients. But then again, so what happens in terms of like families? Are they allowed in the ICU? Ward, are they not? What usually happens if they wanted to come and visit their patient?
Yes, so ICU is a 12-hour shift. We do a 12-hour shift. So our nurses will work 12 hours for 2 days, then go and rest for 2 days. They will come on for 12 hours again for 2 days, like that, day and night. So it's a continuous cycle. And yes, we have visiting time because these patients not only belong to us, they have families out there. They belong to the community as well. So we must be able to engage the community, the family, in taking care of these patients, because our ultimate goal is to ensure that we have discharged the patient back to family.
Back to their family.
So we allow them to come in, and we have very strict visiting hours. However, our ICU is a bit lenient. because our patients require care like round the clock, and therefore our families will visit when care is ongoing. So if that care extends into their visiting time, we will still allow them to see. For as long as care is not going on, we allow them to come in 2 family members at a time.
At a time. Okay. Okay. Sounds fair.
Yes,
Sounds fair, because we also want the patient to rest as much as
Yes,
they can.
exactly.
Okay. Then how long do typically patients, how long are they admitted in ICU before, like you said, they can either be taken to HDU and then eventually to the general ward before they're allowed to go back to their family?
So our length of stay is approximated between 6 to 7 days.
Okay.
For a patient who was just acutely ill, 6 to 7 days, probably 3 days on the ventilator, then we wean him off, and we're expecting, if things are going right, by the 5th day they are off the ventilator, we monitor them for another day or 2, then we step them down. So our length of stay, 6 to 7 days. But, like I mentioned, we have what we call severity index. If a patient comes in with a lot of organ that has been damaged, of course, in 6 to 7 days, they will not be ready to move out of ICU. So they may stay a little bit longer.
Okay. Okay.
Yeah.
I see. And you said you admit patients from 2 months onwards,
Yes.
right?
Yeah.
A lot of people would ask, so if someone is in ICU and then there's all these machines, which we'll actually talk about in the next episode,
Yes.
all these machines, and sometimes they are sleeping or resting. Can they still hear when you talk to them? Can they, because like they're sedated because they need to rest, but can they still hear when you talk to them?
Yes. Patients hear.
Okay.
Patients hear, and it's from that particular note that we are telling our team, please introduce yourselves to patients. They can hear. The ear is the last thing to die. That's what has been said for a long time.
Okay.
Introduce yourself. Explain your procedures to them, because they can hear. You just need to tell them, because actually the patients who've come back to us, do you know how much they remember us?
Oh,
They will always tell us, I could hear so and so. I could remember this. Even though I was dead asleep, they call it like they were deeply sedated.
Yeah.
But I can remember you touching me, you doing this, you telling me this is patients here.
Okay. So how do you know that the patient is getting better? Because again, like I said, a lot of machines, a lot of things, attached, started. It's like a lot of things happening at the same time. How are you able to tell that this patient is getting better, and then maybe it's time for them to be
stepped down?
Yes.
Okay, yeah. So there are a lot of parameters we look at, okay? And part of it is that severity index.
Okay.
We are looking at an organ like, let's say, the kidney. Initially, patient came in, they were not making urine.
Yeah.
And of course, we look at urine mLs per hour. How many mils is this patient making per every hour? And of course, we will judge that by their body weight, okay? So once we see they were initially not making urine, and now we are seeing some urine coming, that's an index telling us this patient is. We also monitor through the blood gases. There's something called blood gas analyzers, okay, which we have here as a point of care. If a patient was severely ill, the oxygen in the blood usually is very on the lowest point, okay? But as they continue improving, we start seeing a lot of improvement in that oxygenation. Okay. So there are a lot of parameters we look at: radiological, laboratory, physical assessment, and generally even the patient themselves. You'll just see a lot of improvement. Yeah.
And then, because again, like you said, it's a lot of medication, sedation. It's a lot for the body.
Yes.
So how then do you support the patient after stepping them down? How do you support the patient in terms of, like, say, the body weaning, of some of this medication? Because we're talking about this earlier. We said some patients might experience a bit of, post-intensive care syndrome.
Yeah.
So then how do you support the patients post-ICU?
Yeah, so post-ICU, that process begins as soon as we start seeing clinical improvement signs.
Okay.
Of course, we'll now start tapering off some of this sedation, because we're able to know patient X doesn't need all this amount of sedative. So we start pruning them down as we drop. And it is during that time now we start engaging our psychotherapists, okay? So the ICU, in our critical care units, we have psychological support that comes to speak to patients, and they also speak to families. Because remember, when you're in ICU, that's a very intense moment for you, emotionally draining. You feel like the world is almost coming to an end. And so what we do, we engage these support systems to be able to speak to family.
Yes.
Okay, to be able to speak to that patient, explaining to them, you know, step by step, the things they need to understand, where they have come from and where we are heading to.
Okay.
So we plan with them. The plan of care is also multidisciplinary for these patients.
And then do you also help them to care for them, how to care for the patient when they are home? Because you see, in a hospital setup is full of professionals that will take care of them. But then when they get home, you know, what happens? Do you help?
Yes, we do. So what happens is that there are patients who we also discharge to home care.
Okay.
Because as Aga Khan, we also have a home health. Okay. So some of these patients, because of prolonged maybe illness, and they are stable, they don't need to continuously being in hospital, we send them through our home health to home care.
Okay.
So we start preparing families while they are still here, because they need to learn.
Okay.
Even though they'll be with our nurses at home, because our nurses do that kind of follow-up, they need to know, in the event this is happening, what should I be able to do? In the event of an emergency, what should I do? Because emergencies can happen at any time, even at home.
Okay, so then as we bring the show to a close, because we have to say goodbye, what is this other myth that you'd like to demystify? And what is it that you'd like our audience to know as far as ICU and critical care is concerned? This is their comment.
Okay. So intensive care units are not death sentences. Yes, patients come here when they're critically ill, but we have good outcomes if they come on time. Okay? For example, we are a stroke center. And for us to manage stroke effectively, we are saying that bring that patient within 4 hours of onset of symptoms. Because the moment they land through our ED, our emergency department, they quickly fall into what we call a pathway. That pathway has very strict guidelines that will enable us follow to the letter to be able to see that we have a good outcome on this patient who has presented within that specific period of time. So ICUs, we have good outcomes. We don't have to fear. Come to ICU, you'll be given information of what goes in here. We shall work with you. Okay? We will work with you and explain to you every detail. That it is your right to have information, that it is your right to choose which doctor you want, that it is your right, you know, to even refuse. But of course, when you're refusing, now we have to now explain to you in details the consequences of probably refusing. But we'll have given you the alternative choices that you may have required.
Okay. Wow. Thanks, Emily, for that. And of course, we're not saying goodbye, like completely. We're done with this ICU, you know, series, if I can call it that way, because next week we'll now get to understand, because like we said, there's a lot of machines. There's this, there's that, there's that, there's that, there's that. I can't even count the number of machines that are in here. So we'll close the show here today. But next week we'll now focus on the different machines that are in ICU, what to expect, and at the same time have Emily help us understand all those machines and what they do, okay? But for now, allow us to say special thanks to you, Emily, and time now for you to take a look at this health tip.
So on today's health tip, we know that CPR is a very common activity in the intensive care. What I want to urge all our nurses and our critical care team is performing quality CPR for all our patients, for us to have good and better outcomes. Quality CPR basically pushes at ensuring that that circulation is reaching the brain, and that's what we need.
Well, what a conversation starter as far as intensive care unit and what it looks like and who gets to admitted in ICU. We had today on the show, but next week on Health Diary, we'll now look at this very machines that you see behind me, and we'll get to understand how do they work. And in case, you know, a patient needs to be stepped down, which we also learned today, what is that process? Well, look forward to that conversation next week. But for now, allow us to say goodbye. My name is Winnie Lubembe. A special thanks to Aga Khan University Hospital for allowing us to film in their spaces. Have yourselves a lovely Sunday. See you next week.